Welcome everyone to our educational video series, the 3 minutes anesthesia. Today we're going to talk about the management of a confused patient in PACU. First of all, when you have a patient who has confusion in PACU, you must go over the differential diagnosis of confusion. Basically, you should rule out the central causes like stroke, hypertensive emergencies, and the major metabolic disorder like hypoglycemia, hypoxemia, hypercapnia, and others. So today's case is about a very interesting cause of confusion. So let's go and see this patient. So basically you have a patient who came from the urology room, 60-year-old male patient who has a medical history of hypertension. He just underwent TURP under respiratory anesthesia. Patient was fine, with hemodynamic stable, until I got a call from the nurse in PACU that patient is getting confused, acting weird, and he vomited once. Because of the history of TURP, you ordered set of lab. Basically, you were checking sodium, and the sodium came back as 115. So you made a diagnosis of TURP syndrome, and here is the big challenge to make this diagnosis. It's very easy to make this diagnosis in this case. The question is how to manage this acute confusion in the light of this hyponatremia. Here is how to start these cases. First of all, you have to know that this patient is acute hyponatremia, then he is symptomatic patient. So the fear of the pontine demyelinosis or the demyelination syndrome is less likely in these cases because it happens more in a patient with rapid correction of a chronic hyponatremia, and basically this patient has signs of brain edema, which are more risk and more important to treat than the possible risk of the pontine demyelination. So what is the definition of a chronic hyponatremia then? Chronic hyponatremia is anything that lasts more than 48 hours. It is chronic hyponatremia. But this patient, his hyponatremia is acute because it is less than 48 hours. So because of this, you should go and treat this patient, and basically the treatment for this case is to give this patient sodium. So how are you going to give the sodium for this patient? First, you have to pick the 3% hypertonic saline and to give the patient a bolus of 150 ml of the 3% over 20 minutes. Or you can give 2 ml per kilograms, bolus over 20 minutes. After that, you have to check the sodium and repeat this infusion again to achieve the rise in the 5 millimoles of sodium. After you rise this 5 millimoles, you have to check if there is an improvement in the symptoms. If the patient's symptoms improved after the 5 millimole rise, you stop the 3% infusion and you start the patient on the 0.9% of normal saline, and you keep checking the sodium every 6 hours. What if this patient symptoms didn't improve after 5 millimole rise? You keep this patient onto the 3% infusion, and you keep this infusion running until the symptoms improve, or you reach the maximum limit of correction in 24 hours, which is at 10 millimoles of sodium. And for these cases, you have to keep checking the sodium every 4 hours. Anyway, this patient should be admitted to the SICU and keep a close eye on the correction. This lecture is based on the recommendations of the European Journal of Endocrinology, and it's published in the 2014. It is a very interesting review, and I would like to share with you. And here is a paper. And thank you so much for listening, and we are excited to do another episode very soon. Thank you so much.